Do you get anxious just thinking about the dentist? Then relax with a visit to Dr. Flora, where trust, transparency, and integrity are key.
We need to rebuild trust in this profession, and that means total transparency. So whether it's seeing the equipment being sterilized or getting a thorough explanation of your dental procedure, there is nothing hidden.
So call Dr. Flora today.
It's time to love your dentist!
So what is hypertension? Essential hypertension is a condition where the blood pressure for the patient is above 140/90. 140 is the top number, 90 is the bottom number. Now, newer numbers have come into play that show that we are concerned when the blood pressure is over 130/80. 130 being the systolic, 80 being the diastolic. So both of those numbers together are very important. It's not just one number or the other. It's actually a combination of both that we're concerned about. How do you take a blood pressure? You actually need to take a blood pressure with the patient sitting. The blood pressure cuff will go around the patient's arm between the elbow and the upper part of the arm. And like I'm sitting now, we actually want the cuff to be at the level of the patient's heart. When you take the blood pressure, make sure that you are, like I said, that the cuff is at the level of your heart. And you pump it up and let it fall down. Now the cuffs that we have are actually automatic cuffs. So I'm going to actually show you how a blood pressure is taken with one where someone pumps it up. But it's important that you realize that it's the same sort of thing that's happening, whether we have one that's automatic or whether someone's taking your pressure. So Mel is going to help us by taking my blood pressure. And as you can see, she's holding my arm. It's at the level of my heart. Now she's putting this artery marker right by where my artery is. If you can see the artery marker, it's going to be right by where my vessels are. So she's pumping it up. And she is going to go about to 200 at least. And your machine will do that on its own. And then she's going to actually let it down. Notice that it's at the level of my heart. That's really important.
124/80.
So my blood pressure is 124/80. And as I told you before, that's a completely normal blood pressure. So when do we need you to let us know and call us about your blood pressure? We need you to call us when the top number is over 150 and the bottom number is over 90. 150/90. We want you to take your blood pressure once a day, like I mentioned before, and we would like for you to record it. And if that blood pressure is over 150/90, we would appreciate a phone call. Of course, we want you to be taking your medicine as directed by your physician, whether that be a hypertensive medication or aspirin, baby aspirin. But we do want you to take your blood pressure once a day and let us know if that number is 150/90. Who gets hypertension? Well, it's a very, very common issue among African American females. And it is actually important that you realize it is called the silent killer. Many people have hypertension and they don't even know that their blood pressure is elevated. The only way to know that your blood pressure is elevated is for you to take your blood pressure. So this is Dr. Colette Brown Graham thanking you for being a part of this program. We so appreciate you taking your pressure and caring about your health. What we want to do is we want to partner with you so that we know that you are actually in the best care possible with your blood pressure being monitored daily. And this is one way that we can do it. We also want to make sure that you know that there are other lifestyle things that you should do. What should you do? You should be making sure that you have some form of exercise daily. I didn't say marathon run. I didn't say go for a 2-mile swim. But going for a walk, going for a 15-20 minute walk, maybe increasing that to 1 to 2 miles a day, that would be wonderful. What else can you do? Maybe having less salt in your diet. We do know that salt tends to elevate your blood pressure. So having a diet with a lot of fast foods and a lot of salt would it actually increase your blood pressure substantially. So these are called lifestyle changes. And we don't want to forget that stress also makes you have a more elevated blood pressure. Sadly, stress is part of most of our lives, and we have to be careful that we don't go, please stop your stress, because it's not that easy just to stop your stress. But there are things that you know make you more stressed, like maybe paying your bills, and maybe someone else during your pregnancy should be writing the checks for the bills, because that's just going to elevate your blood pressure. Or there's other things that you can do to diminish your stress. So those lifestyle things are critical and important, and I would like for you to consider, how can I change my lifestyle, whether it be my diet, whether it be through exercise, whether it be through stress reduction, meditation, something that will actually help you to lower your blood pressure. This is Dr. Colette Brown Graham, thanking you again for being part of this program and hoping that the lifestyle changes, the blood pressure monitoring, and us being closely in tune with your blood pressure on a day-to-day basis will help you overcome the issues with hypertension in pregnancy.
Hi, I'm Dr. Patricia Sharon. I'm a board-certified pediatric cardiologist and a board-certified pediatrician. Today, we'll be talking about infant mental health issues. By infant, I want to define a child 2 years of age or younger. This is a specific group of individuals that really haven't been studied in terms of trauma, in terms of adverse events affecting their lives. We need now to look at this because it's the start of the new being, the person affected by mental health issues as an older child. We have some questions that have been given to us to answer. So we'll start with question number 1. We're asking today, what types of support can be given to an infant who's lost a family member, an infant who is grieving, even though they can't verbalize their grief? Infants actually don't remember much under 2.5 years of age. Numerous studies find that that is the earliest age of memory. So a young child will intend to react when there's a loss of a family member. How do they react? Poor feeding, poor sleeping, waking up after only brief periods of sleep, incessant crying, failure to attain a relationship with other caregivers, not looking the caregiver in the eye, looking away, pulling away, withdrawing. Those items should be looked for when a significant nurturer has disappeared from the life of an infant. Infants actually are born with innate, shall we say, behaviors. One is a startle behavior. They push their arms out and their legs out, and they bring them back in a slow-moving behavior. This is a typical newborn behavior, and if it's missing, we should think about the neurologic status of the infant. Infants have other types of behaviors, like we call it the sort of breastfeeding behavior. You tickle the right cheek of the infant, and they turn their head to the right, and they start sort of mouthing as if they're nibbling, and you can then tickle the left cheek, and the infant turns to the left and begins nursing movements with his mouth. Other behaviors are just flexor tone, increased flexor tone. So infants are inbred with things. And one thing is that they don't remember as a young infant. Nurturing really starts at birth. The infant looks for the eye of an individual, a nurturer. Studies have shown that if you look at the very newborn in the eye and you turn your eyes to the left, the infant will follow you, turning his eyes to the left. If you turn your eyes back midline, they turn back midline, and then they'll turn their eyes to the right. So there are behaviors that they have that aren't verbalizations, but they're normal. And when we have loss of those behaviors, we are concerned about the infant. With the onset of COVID-19, unfortunately, we saw a dramatic increase in domestic violence. In homes, spouses who had no further outlet were taking out negative energy on each other. It seems that when spouses or domestic partners were going to work, there was an outlet, a social outlet, and there was some stability because there was income coming into the house. When that was withdrawn, anger increased. There were no outlets because we were literally locked at home, so violence increased. Yelling increased, and infants had to observe those things. Again, how did they respond? Withdrawal, poor feeding, crying a lot, interrupted sleeping behavior. Sometimes they'll stay up all night and sleep all day, and that's very disturbing because the parents are like up all night. Sometimes these behaviors are considered annoying to the parents, and some of the violence or verbal abuse is taken out on the infant. So this is a time of concern. This is something that we really should think about and look for when we're examining the infant and wondering about something that we call in pediatrics failure to thrive. What can we do as providers, as parents, as nurturers, meaning guardians, to help the infant express with their limited behavior, their limited ability to talk? Well, there are some important techniques that you can use. Nurturing, again, is super important. Eye contact, that special look, the continuous looking for a smile and a giggle from the infant, a little cooing. Cuddling is important. In some societies, cuddling's always done. The infant is placed on the back of the mother and wrapped in a blanket, and that baby is with the mother all day. You know, how really nurturing, how really the infant feels real connectivity to the mother. That's an important aspect when there's been trauma or loss or movement in the home. Sometimes families had to move, and that's disturbing. One thing we use in the nursery, especially with prematures and newborns, is music therapy. Music therapy can be usually lullabies, Brahms lullabies, Beethoven's music. It can be something rather joyful. This helps with music therapy helps with infants who have experienced trauma. It's soothing. A soothing touch also helps the infant. A back massage, a tiny little back massage, or using soothing tools like a lightweight toothbrush can help an infant calm down and feel comforted. We have a question about type 1 and type 2 trauma and how infants sense this and which is easiest for the infant to resolve. Well, type 1 and type 2 trauma happen to infants. And unfortunately, I have to tell you that type 1 trauma, a type of trauma that's a one-time event, but it's a life-shaking, shattering event, can happen to an infant. Infants are very delicate beings. The type 1 trauma may be enough to maim the infant or kill the infant. Things such as hitting the infant. I've seen cerebral bleeding. I've seen punching the infant, broken tracheas. How can you help an infant do that? Severe medical care. But I think one of the most important things that we do as clinicians is when we see that type of trauma, we have to move into the home. We call social workers. We call the DCF. We ask them to come in, look at the home, and real important, there are frequently other older children in the home, and we resolve these problems. It seems that while we're evaluating what's going on in the home, the infant is taken from the home. So there you are with type 1 trauma, something sudden that happens to the infant, a burn. How do we resolve that? We take the baby from the family and we put them in a nurturing environment. That's all you can do. A type 2 trauma refers to repetitive trauma, and that's probably the hardest for us to see unless the infant comes in with, as we mentioned before, failure to thrive, poor weight gain, infant not developing its milestones. At 7 months, we see the infant starting to tripod and sit on its own. If the infant's missing those milestones and we can find nothing else, failure to thrive, we wonder about what's going on in the home. For an infant, just putting the infant in bed all day, propping a bottle, we don't think of that as abuse, but that is, in a sense, mental abuse. They really depend upon us and our eyes and our smile to keep them going, to make them feel wanted. And I think failure to thrive is one key that's missing. And we can tell the parent about that. We can tell them about propping the bottle, holding the baby, how important it is. Some parents may not know. Some parents are too young to know. So as a community, we can step in and show what development and nurturing is and help that parent improve their care of their infant. So type 2 or prolonged trauma, I think there's ways that we can help out of that unless we find that there are other comorbidities in the home, such as drug abuse, mental illness, those things that we have the Department of Children and Families address. What can we do to support our most vulnerable infants who are experiencing trauma or involved in loss of a guardian or are experiencing some type of moving out of the home and parents moving from place to place? There seems that there should be some type of special child care. There was a question about child care. Is that enough? The typical child care in the state of Florida is one trained provider to 3 infants. That's really a large infant to provider ratio for a child that's working on rebuilding trust, a child that needs to learn what nurturing is again. Probably if we had more areas where a special provider could work for a few hours a day with that type of child, a respite type situation, it would be beautiful if that type of provider could even go into the home and model these behaviors to the mother and let mother play or provider play with the child and see if there are any negative influences that they're not even aware of. Voice tones, use of negative words like nosy, stupid. We want to remove those from our vocabulary when we're working with children. I think that's what we could support the community with. Infants probably don't react differently to trauma, whether there are racial differences, but I think what matters, sort of what we've been talking about before, is how is a caregiver able to mediate those traumatic experiences. And that really depends upon socioeconomic. Is a caregiver themselves able to spend the time? Is the caregiver non-working individual who can spend that day with the infant, crawling around on the ground, playing toys with them, looking them in the eye? That makes all the difference. And that's not a socioeconomic unless that person has to work. What about a person who can afford to have a child play therapist work with their infant? Very good. That could be a financial barrier to getting the adequate help a child who's been traumatized, an infant who's been traumatized needs. Are there racial barriers? Doubt that that's a significant factor unless education, lack of higher education, and financial resources are a barrier. Infants need nurturing. They don't need expensive toys. They need food. They need it at a consistent time. They shouldn't have to cry their head off for the next bottle. They need eye contact. They need sweet, kind words, soft touches. They need a person with the time to do that. Racial, socioeconomic barriers, that shouldn't be a primary problem unless that person has to work. And then our community could provide a good caregiver for that individual and their needy infant. Dr. Nadine Burks Harris put together her experiences in her pediatric clinic in Hunters Point, San Francisco. This is a low socioeconomic area of San Francisco. She looked at over 700 cases of children and realized that the need for ADHD medications, children who were in trouble, had behavioral problems, and also children who had asthma, children who had even diabetes or obesity was another big one. Those children all came from families where there was a problem. The problem, perhaps mental illness in the caregiver, drug abuse in the caregiver, domestic violence in the home, poverty, moving from place to place. She took those events as separate events, and when she added them up, she found that 4 to 7 of those events seriously affected the life outcome of the individual child. So now again, we're talking about infants, and we're saying, do infants really perceive this is going on? They can perceive it. They perceive the negative energy in their caregiver, the lack of touch, the lack of the eye, and they become, if you will, adversely affected by them. Then we talked about trauma to the infant. If at 2 years of age, that infant doesn't establish a nurturing relationship with an individual, that eye contact, that constant caring, that infant may become a person who's, we say, disassociated, a person who has a low threshold for anger. There's a real sophisticated system that Dr. Burke Harris talks about, and those are the brain mechanisms that start your fight or flight reaction. You're in your temporal lobe, you have your amygdala, you have your hippocampus. Your amygdala really senses danger, it senses violence, it sends feedback. The hippocampus feeds into your hypothalamus, which feeds into your pituitary. Your pituitary then causes your adrenal glands to secrete cortisone. And cortisone goes into your system and it gives you this extra energy so you could run a mile that you could never have done before. You can lift things that you could have never done before. These are life-saving techniques. It'll help you outrun the bear or think quickly what to do if I'm being attacked or frightened by a bear. But suppose these events are abuse. Suppose there's an abuser in the home, a sexual abuser, a beater. That child is threatened. Those mechanisms, those neurohormonal mechanisms are elicited. The child has a lot of stress. He has a lot of adrenaline, but there's no release. But there's memory. There's memory that something dangerous is going to happen, something really dangerous happened, but the child can't let that resolve. Suppose it happens again. The child becomes even more heightened by these injuries, the perceived danger, and the child then takes that with them. And one example that was given is a child is sitting in class and his classmate neighbor turns and says something really mean, something that maybe he's heard before at home. That child will overrun his frontal cortex. He'll say, I don't care that I'm sitting in class. I am going to punch him in the nose. And that's sort of actually not that the patient is super violent, it's a response that's been evoked from previous adverse childhood experiences in the home. It could be perceived that the child is ADHD, attention deficit hyperactivity disorder. He's always acting out. Simply treating it with your neural stimulants isn't the answer. The whole importance of Dr. Burke Harris's work in adverse childhood experiences was to get to the root cause, that in the home there's a problem, and the problem may be salvageable, and that child may go on and experience a better lifestyle. These adverse childhood events were associated with increased illness and even a 20-year decrease in the lifespan of the child. Now, can we take this whole scientific data and trickle it down to the infant? I'm not 100% sure that can, but we know that that child, if left with the same nurturer, the same provider, the same parent, grows a little older and now perceives what's going on in the home, and it becomes that child who has what we say ACEs. There are questionnaires that pediatricians can ask in the office to get some idea of what's going on in the home and if that child's involved. Those would be just, are you being pushed or grabbed by someone 5 years older than yourself? Are you being yelled at? Are you being called depreciating names like stupid? Or, if this is going bullying, someone's constantly taking your dinner from you, older sibling. These are adverse childhood experiences that create an older child who has health problems and emotional release problems. All right, again, we were talking about infant mental health and infant developmental. One question we looked at was, how do infants learn? How do they learn who their mother is? So there was an interesting experiment that you may have heard about by Dr. Konrad Lorenz in 1952. He looked at mother goose and geeslings. Okay, when the little geesling is born, hatched, the geesling follows the mother. Dr. Lorenz intervened. He took another set of geesling that hatched, but they never saw their mother. He interrupted that interface. He stared them down for up to 17 hours after they were born, and those geesling thought that Dr. Lorenz was their mother. They followed him everywhere, and he, of course, was now the new provider for little geeslings. So infants, nurturing is an eye contact, an emotional bond between the newborn and the mother or caregiver. Caregivers may change in the first year or two of life for various reasons, but it's around 2 years of age that infant really attains his ability to establish social relationship and see someone as a nurturer and not as a non-specific person that they can't relate to. That raises another important issue in our society. Mothers have to work. I've had to work. So after 6 weeks or 6 months, mother goes back to work and leaves the baby hopefully with a nurturing provider. How does mother continue and reestablish that relationship? You have to stay those extra hours up, making the eye contact, playing, and perhaps on the weekends, let those dishes go. Find some mommy and me time or daddy and me time to develop that relationship, because really after age 2, it's really a looser bond that you have. It's the first 2 years of life. So mothers, try to give your child that time. Carry them around. Make yourself a little sling where they're always with you. Thank you. In summary today, we've talked about infant mental health. And truly, infants do see, they perceive, they react, and they react negatively to negative environments. If I were to do anything today, I would say, that nurturer, that caregiver, they should really focus on eye contact, gentleness, playing. Infants need to play. They should realize that giving the bottle is not just enough. Oh, he's crying. Here, take a bottle. What's causing the crying? Maybe the infant is bored. Maybe there's gas. Listen to the infant. Try to pay attention to what they're saying. There are different cries, for example. There's the hungry cry. There's a I'm sleepy cry. There's a frightened cry. Try to perceive what's going on. Your infant is going to become your child. It's going to become your adolescent, your teenager, and it's hopefully becoming a productive adult. And what happens in infancy can follow the child through life. Let's give our infants a better life. Let's try cuddling. Actually, I think we are not carrying infants enough in our arms. There were some infant carrying items that put the infant in front of your face all day. So they weren't just being pushed around in a buggy. Other devices, we talked about the infant on the back of the mother all day. How nurturing is that? Let's think of better ways of raising our infants into productive adults, okay? Thank you.
Hi, I'm Dr. Tiffany McCalla. So happy to be here with you. I'm a board-certified emergency medicine physician as well as a wellness physician. The goals of discussion today is to learn the importance of mammograms and self-exams, to learn the specifics about breast health issues for women of color, particularly the triple-negative cancer, as Black women are much more likely than white women to get triple-negative cancer. Unfortunately, this is the kind of breast cancer that is often very aggressive, and it comes back after treatment. The CDC defines types of breast cancer a woman can get. It's important for you to know what you can do to advocate for your own health and for women in your family.
Hello, I'm Dr. Donna Kleban. I'm a board-certified general surgeon, and I specialize in the treatment of breast cancer. I would like everyone to know that there does not have to be any fear about finding out if you have breast cancer or fear during breast cancer treatment. We've been very successful in our practice. We have not lost any patient to breast cancer in the last 20 years. There are several theories as to why women develop and men develop lumps in their breast and changes in breast tissue. There's no one specific cause. One factor is diet, certain things we eat in our diet which may affect the breast tissue, the breast glands. Hereditary can play a role. Also our environment, toxins that we may be exposed to, products that we use, and that's something I would like to speak about a little later. Not all breast tumors need surgery. Breast tumors can be liquid-filled, which are called cysts. Those usually do not need surgery because they don't pose a problem. There are a lot of lumps in the breast or tumors in the breast that are not cancerous, and often we only have to find out what they are with a simple biopsy that's done in the office, and they do not necessarily have to be removed.
Dr. Kleban, thank you so much for spending time with us here today. I just want you to educate our people. What are the things that they just need to take home from this whole conversation?
What I would want to say is that women and men should not be afraid of breast cancer. All breast cancer is very treatable. We have terrific newer treatments, medications with a lot less side effects. The problem is if you have fear and you don't get care, then it can be more difficult. We are here to help you, to take care of you, to listen to you, to be your support group. So please, let us do what we have a passion for.
Thank you so much for that. And I know that our viewing audience has definitely benefited. I'm Dr. Tiffany McCalla with T. Leroy Jefferson Medical Society, and we thank you for your time and We just hope that you are able to use this information to care for yourself and your family.
Joining me is Dr. Shanteria Dixon. And Dr. Dixon, thank you for taking the time out of your busy schedule to be with us today. But before we get into questions, you've got a story to tell me about how you got into emergency medicine.
Yes, thanks, Sandy. Thank you so much, and it's nice to be here with you today as well. Yes, I was hit by a drunk driver when I was 13 years old in one of the streets here in West Palm Beach on Palm Beach Lakes. I was blessed enough to meet an amazing orthopedic surgeon that night, Dr. Richard Weiner, and I started shadowing him during my recovery phase and became enamored with emergency medicine.
Oh my goodness, what a story. How are you now? I mean, do you still have like effects from way back then?
I'm very blessed. You could not tell that I got hit by a car and broke both my legs and my pelvis.
Oh my goodness. Well, talking about emergency medicine, and a lot of people, when they get into accidents, that's how they start their opioid journey, right? They get prescribed opioids for whatever reason, okay? Let's talk about how are opioids used within the trauma emergency setting and your scope of practice?
So emergency medicine, we take care of a wide range of patients. We take care of pediatrics and children all throughout all the adult years, even into the elderly. And in our field, we also have a very wide range of pathologies. We can take care of, STD treatments to traumas with fractures to even some pregnancy-related complications. So a lot of different pathologies that we care for. And some of those pathologies do have acute pain, which is usually the primary indication for opioid medication treatment.
What are some of the personal experiences within the emergency room with opioid overdoses? Now, you started talking about it, how it's treated for pain. So what are some of those experiences that people have that, would cause an overdose?
Okay. So I think you'd unfortunately be hard pressed to find an emergency room doctor who has not treated many opioid overdoses. There's different categories. There are accidental opioid overdoses, and then there are intentional opioid overdoses. The majority that we see here are accidental, meaning that you ask a patient, were you trying to harm yourself or kill yourself? And they say, no, I was just trying to get high. Unfortunately, a lot of the opioids we see are contaminants of some of the drugs that people are using. So someone thinks they're snorting cocaine or thinks they're shooting heroin, and they can be contaminated with fentanyl, which is a much stronger opioid and is causing a lot of deaths in our community.
Let's talk about some of the opioids that you see in here. Okay, whether it be synthetic, what are some of those opioids?
So truthfully, most of the time we don't know. Okay, we have an opioid test in the urine. The one we use in a lot of adult emergency department does not differentiate between synthetic and semi-synthetic and natural opioids. Talking about the natural opioids, you're thinking of things like morphine and codeine. The synthetic opioids are more like fentanyl, methadone, and for the semi-synthetic, oxycodone, hydromorphone. There are some tests where you can differentiate between the different narcotics, but the treatment is still the same for an acute opioid intoxication or overdose where there's respiratory depression or respiratory failure, meaning the person is no longer breathing. We use Narcan, which is an antagonist to the opioid, the mu receptor. So for us, it doesn't really matter too much which type of opioid it is, which is probably one of the reasons our urine drug screen does not differentiate. It's also very difficult to differentiate the synthetic opioids because they're constantly changing. A lot of the manufacturers are trying to evade that opioid drug testing. So they're constantly changing a little bit of the chemical structure so that even if you do have a test that picks up a certain type of fentanyl today, in a couple of months it may not pick up that drug. So it's really not as feasible to figure out exactly which opioid is being used.
So that must be difficult for you in trying to assess a patient if they come in here and they appear to be going through an overdose then. How do you?
Not necessarily. It actually makes our job a little easier since the treatment is the same. A lot of these patients, if they are critically ill, if they're not breathing on their own, or if they're having difficulty breathing on their own, we're going to give them Narcan. We start off usually with the lowest dose possible to prevent withdrawal symptoms, which can come on pretty quickly. And it doesn't matter if it's a fentanyl overdose, it was unintentional, if you need the Narcan, we give you Narcan. And it's the same treatment regardless of which class of opioid it is. So for us in the emergency department, it's easier. And on the patient side, it's difficult. We give them caution and just tell them, you have to be very careful because even though you think you're smoking marijuana or you're snorting cocaine, we've seen a lot of contamination with fentanyl and opioids, and you may precipitate a respiratory failure and a death that's preventable.
How do you determine whether a patient needs opioid for pain management in an acute setting?
So usually in acute setting, we try our best to limit opioid prescriptions and treatment. We first try non-opioid methods such as acetaminophen, whether that's IV or PO. We try non-steroidal medications like ibuprofen and Toradol. There are other topical treatment options such as a pain patch. There's also regional anesthesia such as nerve blocks and hematoma blocks if you have a fracture. And then there's also non-medication techniques, so warm pack or a cool pack. If opioids are, however, necessary, you definitely want to start with the lowest necessary dose to achieve pain control. And then if you have to prescribe it for a longer period of time than 1 or 2 doses, there's a limit to 3 days of prescriptions for the opioids from the emergency department.
Do you talk to patients about that and tell them about the possibility that they can get addicted?
Absolutely. We always have to have a shared decision-making conversation with the patient. And in that conversation, you want to discuss the risk and the benefits of opioid medications and taking them. So there are also other side effects such as constipation, nausea, vomiting. So it's not kind of the one end-all be-all to end your pain. And we let patients know that sometimes if you maximize your usage of appropriate dosing of acetaminophen or ibuprofen or Toradol before, you may not even need the narcotic. So if I'm prescribing a 3-day course or less of narcotics, I make sure to tell them that there is a risk of an addiction, there's a risk of side effects, so please only use this if you absolutely need to for breakthrough pain or severe pain, and try to maximize the non-opioid options first.
How is methadone different from other opioids? We hear a lot about methadone. So can you break down that methadone and tell us how that's different?
Yeah, so methadone is one of the longer acting opioids, meaning that it sits on the mu receptors for a longer period of time than things say like fentanyl or morphine, although there is a longer acting version of morphine. But the basics is that it's a longer acting. Because it's longer acting, you have less of the euphoric type effects that you see with some of the shorter acting morphine, and it has less potential for abuse because of that. So it can actually be used for chronic pain because of some of the properties of the medication, and it can also be used for opioid use disorder. And a lot of patients who are on methadone go on to live, normal, productive, illicit, drug-free lives with methadone. It's not for everyone because there are some side effects. There are quite a few drug interactions, so it's not for everyone, but it is a good option for people who are attempting to become clean off of illicit drug use and have a more sustainable lifestyle.
How long do they need to be on methadone?
It depends. That's a great question, but the answer is it depends. Some people are on it for the rest of their lives. Some people use it for short course, but it all depends on the person and their personal situation.
Doctor, what are some of the other drugs that are used to get people off of opioids? We just finished talking about methadone. So what are some other drugs that you use?
Buprenorphine is another agonist that is used to try to detox individuals from opioids who have opioid use disorders. Recently, they have changed the recommendations of needing an X waiver, which previously physicians would need an X waiver to prescribe this medication, but that's no longer the case. So now more physicians have access to this medication and can prescribe it to patients who are suffering from opioid use disorder.
For us who don't understand what is an X waiver, can you explain what an X waiver is?
An X waiver was basically a special certification that indicated that physician had extra training on how to prescribe this medication for certain indications and how to manage it as an outpatient.
Okay, so and what's the next? So we have methadone, buprenorphine, and what's the next medication that you can use for? Where does Suboxone fit into that?
It's in a similar category. So it's just basically the drug brands and the different names of the medications. But methadone is kind of in a separate category than Suboxone and buprenorphine. But
and what's that category?
Opioid antagonist. They're basically they are the opposite of opioids. So opioids bind to mu receptors, which are some of the receptors in your body, and they cause calming effects, respiratory depression, slow your breathing, pain control, and the other drugs basically bind to those receptors as well, and they kick off the opioid. So if you overdose on, say, heroin, if I give you Narcan or one of these medications, it will basically competitively bind to the receptor so that we can reverse the effects of the drug that you had ingested.
Wow. Is there anything else you want to tell us about? I mean, 'cause you got a lot.
Yeah, I think We have a very difficult job here in the emergency department, and that's to assess critically ill patients and patients with acute medical conditions and treat them appropriately. We unfortunately don't have the ability to sustain that long-term relation that's needed to prevent relapses. We know that a lot of patients with opioid use disorder, it's a chronic medical condition, and it's not something that you can cure once with one dose of Narcan or one intervention. They're going to need lifelong support. So there are a lot of different resources available. I know the Healthcare District Clinic has available. There's other different mental health counseling centers that have treatment, but we just have to get the word out that this is a medical condition that is treatable and needs to be treated. Or else we're just sending so many preventable deaths, and it's always very heartbreaking to tell a family member or a friend that we weren't able to revive their loved one, especially since it's such a preventable death.
Tell me about what are some of your personal experiences in the emergency room with opioid overdose that sticks with you today?
Yeah. So unfortunately, it happens quite often. We could have an overdose once a shift, or we can have an overdose 3 or 4 times a shift. It honestly really depends on what's circulating out in the community. We can always kind of tell when there's a bad batch of a contaminated drug because we'll get multiple patients from the same area multiple times a day throughout the whole weekend. And then usually it calms down, but it's very, it's not predictable, but it's consistent that we will have overdose patients. What's pretty consistent even across the country is that after we do revive them with Narcan, they're usually ready to go. So we have very little time to intervene and do counseling. A lot of them sometimes leave at the scene. If they are revived with Narcan by a paramedic, they get up and leave. They don't want to come to the hospital. If they do come to the hospital, a lot of them request to leave very shortly thereafter. And if they are alert and oriented and have capacity to make their own decisions and they're not critically ill, we don't have a legal grounds to, detain them into the hospital. So that's a difficult part of it. We still make sure to give each of these individuals a prescription for Narcan, and I also give a prescription for Zofran because sometimes if you use it, it can precipitate nausea and vomiting, and a list of local rehab facilities. A lot of times, if they don't come in from a rehab facility, which happens, if they come in from home or from the streets and they've recently overdosed, a lot of these individuals, unfortunately, are not ready to seek mental health counseling and rehabilitation. But we provide them with a list of facilities so when they are ready, they know that that's an available resource and they are able to take advantage of the tools that they have.
Opioids is a revolving door. How do you separate it when you walk out of this hospital? How do you separate the traumas that you see and get back to just your own life?
It's very difficult, and I'm still learning the art of that part of medicine. I think the most important part of this is to have something that you love and truly care about in a job and at home. And I am so blessed to have both. I have an amazing, loving family. I have a great group of really close friends that I cherish. But I also really love my job. So it makes it easier to deal with the consistent traumas and stresses and frustrations here because I know deep down that I'm making a difference and that I'm able to help people. And I truly believe that's what God placed me on this earth to do. So I kind of have a requirement to do it and just to keep trugging.
Dr. Dixon, thank you so much for taking time out of your busy schedule to meet with us. I've learned a lot in this last hour that we've spent together. And thank you for all that you're doing for our community.
Thank you so much, Sandy. It was a pleasure.
The opioid epidemic is destroying lives, and the addict is not the only victim.
So Kevin, this is day one. Just walk in the door. What happens on day
Kevin
one?
Choi walks me through day one at HARC, the Harm Reduction Center he runs in Boynton Beach. A reflection of his life story and struggle with opioids, a struggle that once had this CEO at the very bottom.
How do you become the founder of a treatment facility, from a drug addict to a CEO? How did that work?
That is a good question. Honestly, I think it happened through instinct and then support, or really all the people around me that supported this, So, no man or woman or no human being is an island. That is true. Same with somebody's recovery. Everybody needs somebody. God blessed me with multiple people. I'm originally from Los Angeles, California. Went to college out in Boulder, Colorado, where I studied psychology and philosophy. Well, it really started, I would say, in high school. I was injured in a football game. I broke my arm. I was prescribed Vicodin, and it really was just something that I didn't understand. I know it made me feel good. And then as time progressed, as you get older, as you are exposed to different environments like college, like partying, like all these different things, what ends up happening is that serves a specific purpose, whether it makes you feel good, it's a social lubricant, whatever it may be. And for some of us, there's a genetic predisposition to this stuff, and before you know it, you're really off in the deep end. And that's just what happened to me, and I didn't even know it happened.
Did you struggle with fitting in?
Absolutely. As you can see, I don't know if it's tough to tell, I'm like a second-generation Korean. I knew I was an outsider, But the thing is, during this journey, I found out that really the only person that has to feel at home is really for yourself. And that kind of work is why all this stuff is very important. Is it helps solidify you as an individual. A lot of what we see is perhaps on the surface level, and it takes a lot of deep dive into who you are, what you've experienced as a person, to kind of go through why these things happen, and find some sense of solution. Hopefully what that means is, some peace, some happiness, some abstinence, but also want to have some support systems out there where we're not really fitting folks in boxes, And that's sort of where I guess this company came into play, was my own personal experiences with opiate addiction.
I'm mesmerized right now. At what point did you realize that I can't keep doing this? I need to get better. When did you realize that? How did that come about?
I really knew I had to stop. Really when I had no other options. Literally I had perhaps, or what I thought at that time, burned every single bridge. I had no more resources to keep my addiction afloat, and the only thing I really had left was a car and time, But yeah, I specifically remember a look that my dad gave me, and my dad and I have an interesting relationship. However, a lot of things are said without actually being said. And I remember I was outside in the backyard, and he specifically looked at me, and I remember he wasn't looking at his son. He was looking at me, but I could tell he didn't recognize anything about me at that time. And I remember feeling and I'll never forget that look, and that was a very deep scar in my heart. Man, I've hurt people around me, and that was all self-inflicted, all self-meditated, and I put myself in these situations. There needs to be a sense of responsibility on my side, while also learning to try to reduce the harm that I cause around me. And that's, obviously a major reason why we named this the Harm Reduction Center, is so much of what addiction entails is destruction in the family, in the community, and so everything we do has to do with reducing said harm that's being caused by, a patient or a client and their active addiction.
Though Kevin's family also struggled with his addiction, they played a key role in rebuilding his life and building this company.
Family was absolutely key in all of this. However, it took, both sides needed education. So myself and my parents, or my brother or my loved ones, anybody in that nucleus of, I guess, loved ones really, they had no understanding of what was going on with their child. They said, what do you mean you're addicted? What does that even mean? Why can't you just stop? All these questions start coming up. I know they blamed themselves for a lot of these things, but once they began educating themselves, and once I got further educated, I put more effort and time into my recovery. They did the same things for themselves. And what ended up happening is it enriched our relationship. However, it was difficult. It requires every single family member to take a look at themselves, even though this is sourced from perhaps outside of themselves. And so it's quite tricky, but I was incredibly blessed and fortunate to have a loving family that stood by my side through that entire process, almost a 10-year process. And we're not talking about, butterflies and rainbows. We're talking about, I was in the throes of it, and so how do you expect folks who've come here from Korea and, they're just trying to make a living for their kid and make sure that their kid can go to college and get educated, and, they get a call and his son's in the ER and he had overdose or something, multiple times, seizures in college from benzo withdrawal. It's just absolute mayhem. And it was to the people I love the most, And so balancing that relationship has perhaps, been another key point in the past 10 years of my life. And creation of this company has everything to do with that,
From mayhem to calm, Kevin tries to bring a sense of that in this hallway, where the artwork acts as therapy.
Addiction doesn't discriminate. We talked about that in detail about addictions and race, and it's depicted here.
Absolutely.
How powerful is that?
It really doesn't discriminate.
A lot of people don't want to talk about that, but let's talk about that. Race and addiction.
Yeah, it's tough, it's weird, it's like, I didn't think anything of it until I actually thought through it, and I realized how many barriers were in place that weren't just picking up a phone and calling a provider to help get sober. I'll speak on my family sphere a little bit. At least in a traditional Korean household, this kind of stuff isn't something that's spoken about readily. My family is incredibly religious, and we follow, Presbyterian Christianity, and so it was even tough to battle through those kinds of barriers to break through, and it was tough conversations. It was, they've never had to experience this before, so it was all hush hush. Let's keep it, behind closed doors. If it creeps out a little too far, we'll have to find a different method to cover it up, kind of situation for some time. It was like, we don't know what to do with him. We know we don't want to, let folks know or let the world know or admit to the world that, like, our son has a problem. That doesn't determine whether or not he can be a CEO and sit in a chair, but he has got a problem right now, And for so long, I tried to hide it, they tried to hide it, and it was something that I know still to this day, 7 years after, May 1st, 2014 is the date. After all this time, it's still difficult for us to even have those conversations. And it's like, I understand, people talk about, hey, it takes a long time, like that they mean a long time. Relationships like this take years to rebuild. On top of that, they're growing and changing. And so, yeah, it was just quite an experience. So you're talking about a traditional Korean household with a kid like me, a rebel, I guess, somebody that really just flew off the handle, and my job at that time when I'm in active addiction is just burn my life down, And that's something I was very good at, and I could do it very quickly. And I don't think they understood what was happening. And so they didn't know who to talk to, they didn't know who to go to, so they went to the church. It was a natural reaction for them. It was like, let's go talk to our pastor, what do we do? Thank God we had an English ministry at our church. We had a younger, English-speaking pastor there, And he and I were able to sit down, and I think he understood specifically that this is beyond his scope of like, hey, you can't just pray this stuff away, you know, you gotta go out and find it. It was just difficult because I was like, dude, I'm gonna have to walk into a rehab, probably where nobody looks like me, to talk about issues that I don't think the person in front of me is really even going to understand. You know, like, what are you going to know about growing up eating kimchi and like, you know, all that kind of stuff. Like, it was tough for me to like, you know, and even now to this day, I've been here almost a decade, you know, and like that sense of that home, that part of me will always be there. And to kind of, at that time, what I felt like was, you know, a sense of disrespect to that structure in my life. It was hard. You asking me to be honest with the people that I've tried to, you know, keep a correct image with for many, many years. And it was just, yeah, I didn't know what to do, and it was tough. And I knew that not only am I going to have to walk into a group room or a therapist and explain my life and what's going on, but like everybody, the first thing that they're going to notice about me is not the fact that I'm in trouble. It's the short Korean Asian kid here in rehab. You know, that's the first. And so immediately I was like, that's one barrier that's inhibiting me from what I believe feeling comfortable enough to perhaps express certain things, go through certain experiences. And that was so hard. It was like, and nobody understood, you know. And it was, and even now we're like, there aren't a lot of Asian Americans in treatment, you know, and even now there are very few Black and brown folk in treatment also. You're talking about minimal minority participation in treatment from you know, and I know this is like a, you know, I don't have hard numbers right now to discuss with you, so I'm not going to, you know, just a blanket statement. But what I do know is that I know that the problem is pervasive. Getting to said solution is problematic. It's tough in these minority communities. Yeah, and so that's another big piece of why I do what I do. There are folks that look like me, that have had experiences like me, who perhaps feel even further alone because of the way they look, of the way the world perceives them. And it's sad, difficult, another hurdle to go through. However, it does add to every single piece of your life. So it's a double-edged sword. It can hurt you. You can use it the wrong way. Other folks can, you know, hurl insults at you and try to, you know, knock you down kind of situation. But, you know, at the end of the day, in rehab, you look at the guy in front of you, he could be worth $100 million, he could be worth nothing, and you know that you can connect with this person immediately, you know? And that's like the thing that I wish the world knew more of, was that when you take that initial filter off, it's pretty simple and easy to connect with the person sitting in front of you, you know, aside from race, sexual orientation, religion, and all these isms and differentiating factors between us. It's really just about seeing the person as they are. And that's something that, like, I wanted to practice as an individual. I know it's not going to be practiced by every single man or woman around me, but that's how I want to live my life. That's how I was taught to live my life by my family, and I cherish that kind of stuff. And what ended up being perhaps the largest barrier coming into treatment was the race thing, the language barrier. Like, how is a therapist going to call my Korean-speaking parents and explain to them, hey, I think your son's dealing with depression, anxiety, he needs to be put on this specific medication. You know, like, you don't know what that means, you know? So perhaps that barrier, what I thought would be the biggest hurdle, ended up being perhaps the largest reason why I continue to work. You know, it's like, this is what drives me, you know?
You see Black and brown people coming here every day, and they are struggling, and they're struggling with cultural issues. They're struggling with, you know, they can't stop. They're on a path to self-destruction. Yeah. What happens when that person walks through that door?
hopefully what happens is they get a sense of, you know, being a part of some kind of family that's not based on race, religion, sexual orientation, anything like that. The only mission we have here is to make one feel included as they empower themselves on this journey to get better. And better can look a million different ways, you know? It's really between the patient or the client and really whoever or whatever, you know, clinician or doctor they're with.
The work to break down barriers is reflected in Kevin's diverse staff.
First off, right, we need to look at how does our communities view substance abuse issues.
Richard Warren is a licensed clinical social worker.
We need to understand the barriers, particularly when somebody is willing to come through that door and ask for help. What barriers may they be bringing with them that we may need to overcome? Opening up, sharing about personal experiences is not easy for anyone, particularly Black and brown community. And I think for us, it's very important to have individuals that look like us and be able to recognize that regardless of the person's struggles, they're also bringing history, they're bringing experience, they're bringing culture with them. And we cannot neglect to recognize, honor, and cherish that culture. A lot of times what I hear, especially in the Black and brown community, is that nobody wants to talk about it. There's a lot of substance abuse, particularly here in South Florida, and a lot of times either people turn a blind eye to it, they believe that it's not a problem that someone can stop on their own, and that they don't need help. And a lot of times, particularly with people dealing with opioid addiction, is they have a desire to suppress emotion. And the important thing is to allow them to understand that regardless of what they're going through, seeking help is not a bad thing. It's okay to ask for help. And understand that it is a problem that most people cannot take care of on their own, and that's okay.
You're not alone. A similar message shared from the pulpit.
Or whoever you believe in, that higher power will help you get through this process. And pastors have to provide that safe space or be a part of removing that stigma that's attached to mental illness and drug addiction.
How can pastors do that?
One, we could start talking about it from the pulpit. We could start letting our members know that after I lay hands on you, after I pray for you, after I anoint you, there's a space where you can go to get help. There are people who want to help you. And that's the role that I believe pastors can play in finding great spaces or safe spaces to recommend that the parishioners go.
A place to go, like Hark.
There have been stark increases in differences between race and access to health care. So it is our job at this facility as a provider to increase said access and decrease costs and try to work within the bounds of outpatient where somebody can work, can function, and ultimately have a semblance of normality and balance in life, you know? Live in this moment, live in this day. Don't extend yourself too far. You know, and really, like, you're not alone. There are millions of us out there, and probably more. And especially with COVID and everything that's been happening during this time, it seems like things have gotten harder. You know, the pandemic was kind of like everybody was juggling 10 plates at once, and the pandemic was the last thing that kind of just dropped everybody's plates, and a lot of destruction happened. So it's okay, don't judge yourself. Reach out for you know, any type of help, even if it's just a phone call to talk to somebody about how your day is going. Something simple like that could potentially lead you down a path of self-discovery.
The pharmacist is the first and last line of defense. Doctors are seeing signs of addiction at the counter.
My name is Keaton Grant. My background is as a retail pharmacist working in the community and also a clinical pharmacist working in the hospital setting as well.
Dr. Grant, what role does the pharmacist play in the fight against opioids?
We have the final say who gets these medications, and we also are the ones that are able to identify if there are patients that are showing signs of drug-seeking habits or might be dependent on these medications.
How do you know? What are some of the signs that you see that a person may have a dependency to opioids?
One of the biggest telltale signs we'll see is a patient that will call in every single month, sometimes every week, and claim that someone robbed them and stole the medication and they need an early refill for whatever reason, or they lost it, or they're always asking you for a favor. Can you just give me a few just to get by? It's just severe drug-seeking habits that you could tell it's unusual because they're not calling about blood pressure medications like that, you know.
How do you deal with that?
You have to tell them no. A lot of these patients are extremely persistent, and they are like they do not take no for an answer. They will call you 4, 5, 6, 7 times a day, every single day, back to back. And it is a lot to deal with, and they will show up to the pharmacy sometimes in person and try to almost strong arm you into giving them what they want you to give them, which is these pain medication that they started taking for whatever reason.
Explain how the prescription drug monitoring program works.
You could tell from the prescription drug monitoring program if the patient has ever taken this type of medication before. Like, you could tell if it's a patient that's naive to opioid use. So if it's their first time, you're gonna want to say, why did a doctor write for this medication? Maybe the strength might be too high for a patient that has never taken this medication before, or the quantity is way too much. Like, why would they give them a entire month's supply if they've never used it before and they don't know if it works? Or why would someone need 30-day supply for a dental surgery? So it helps us identify those patient groups, and also it helps us identify patients that are getting multiple prescriptions and going to various pharmacies, and they have a thing called pharmacy shopping, where they'll drop the same prescription off everywhere and get a stock up on a whole bunch. So it helps us stop that from happening. And also we could see if they're taking other controls, because they create cocktails, because one of the biggest things that cause the overdose is if they add like a Xanax to the Percocet. You could see if they're taking high doses of other medication that could lead to them overdosing or being dependent.
Briefly explain how a pharmacist has gone from a pill pusher to a critical frontline worker.
So the pharmacist got a lot more involved, because once the opioid crisis started and they started seeing like alarming rates of people overdosing, the biggest issue is people go from these pharmaceutical medication and they turn to street drugs after being given them for a period of time. The only person that can really tell if a patient is like acting like they're addicted to it would be the pharmacist, because we'll be the ones to see them come in every single month. They might go to different doctors. They might do doctor shopping, they call it, where this doctor won't give them the medication anymore. They're going to go to another doctor. So the physicians have no real way of seeing if a patient is doctor shopping. So the pharmacists, when they created the system, the drug monitoring system, is because the pharmacist is the only one that can really identify these issues.
What trends are you seeing behind the counter that are concerning to you?
The main trend that I'm seeing from behind the counter that are concerning is a lot of the habits that started back in like the 80s and the 90s that created the opioid crisis in the first place. We're still seeing them in a form of pain management doctors that are still writing for large quantities of opioids in combination with each other, just like they did in the past. So a lot of the things that caused the issue are showing up again, but in a new form of so-called pain management doctors.
Dr. Shakoya, Dr. Grant's wife, works where there is a need for opioids.
The opioid epidemic, it's very unfortunate, but we have to remember that there's various groups of people and individuals who still need these opioids for quality of life. So for instance, in my setting, cancer patients are definitely patients that we cannot ignore and who have a strong need for opioids.
Do you think that we can combat this opioid problem, and what needs to be done?
What I think can be done is honestly providing education that, opioids are good at helping with pain, but they do have the risk of abuse. And we need to identify patients who are at increased risk of abuse.
One of our doctors says the opioid crisis isn't just about heroin, and it may take a look at our past to change our future.